provisional diagnosis will be. So yesterday I told you one thing about these questions. The groove means like something viscid material. The groove means thick material or the clot like substance. Okay, and we are seeing that this is the 29 weeks of pregnancy, and here what we are seeing that is the fourth labor to comes, means she is having the preterm delivery. She will be having the preterm delivery and was admitted to the obstetric department with the complaint of the sudden and painful bloody discharge from the vagina that appears the 2 hours ago. The discharge that appeared the 2 hours ago, so means painful bloody discharge 2 hours ago. This will be, of course, that will be the fresh blood will be there, and the fresh blood where we studied, the fresh blood we studied in case of the placenta previa. So this is the case of the placenta previa, and the placenta previa is what? That is the placental purgentations. Now we studied that in case of the placenta previa that this is the painless condition. So we was right. So write where you wrote the placenta previa, write one thing there where you write the painless, the pain in abdomens. The pain in abdomens will be, there is no pain in the abdomens. Then write in the bracket of that except in preterm labor. The except in preterm labor. So if you are having the preterm labor, so remember in case of the preterm labor, we will be having the pain in case of the placenta previa. So this one word was skipping from yesterday point. So write this point. If the painless is there, the except in the preterm labor, that's why we gave the painful condition here, that is the preterm delivery. And the preterm delivery we will be having the painful conditions. Other usually what we see, that is the painless. Other things what we studied, that is placenta previa occur after 28 weeks. There is a fresh blood color, that is a bright red in colors. Then what we are seeing, the warning hemorrhage sign will be seen in this condition. Other than what we studied, the uterus, how is the uterus will be? Uterus was relaxed, soft and non-tender. So all these things I already wrote there in case of when we discussed about the placenta previa and discussed about the abruptio placenta. So correlate with that things, and in that things write where you wrote the painless conditions. So in bracket of that you have the space in between. So write there the except in the preterm labor. In the preterm labor we will be having the painful conditions. So that's why this answer will be the placental purgentations. The detachment of normally located placenta, that is the abruptio placenta. So this is not the case. Okay, so this is the case of the placenta purgentation. Placental purgentation means where it is purgent, like it is above the internal os or like within the 2 cm of the internal os, that is the placental purgentations. Okay, then we was on the question number. Okay, I hope this question is clear to all. Okay, so just write that line in your where we discussed about the placenta previa. Then the question number 39. Question number 39. 39 we did. Question number 40. So question number 40, remember, if you having the condition of the parturient woman has been good for the 2 hours, after the live birth, uterus is thick and the globes. The uterus is thick, globe shape, its bottom is at the level of the umbilicus. Then bleeding is absent. The clamp put on the umbilical cord remains at the same level. When the woman takes a deep breath, she is being pressed over the symphysis with the verge of the hand. The umbilical cord draws into the vagina. So bloody discharge from the sexual tract are absent. What is the doctor further tactics? Okay, so this condition is what it means, that if we are seeing the uterus is thick, globe shaped, the condition of this is the parturient woman. That is seen in the labor has been good for 2 hours after the live birth. Okay, means delivery has been done, and after the 2 hours we see the uterus is thick, we see the uterus is globe shape. At the bottom of the lubula, at the level of the umbilicus, we see the bleeding is, there is no bleeding, no bloody discharge. The clamp put on the umbilical remain at the same level. Means we have discussed that during the once the placenta has been ruled out, so there will be the lengthening of the umbilical cord. Yesterday we discussed the lengthening of the umbilical cord, but we can see the clamp that we put on the umbilical remained at the same level, means the umbilical cord or the placenta has not been separated. When the woman takes a deep breath, she is being processed over the symphysis with the verge of hand. The umbilical cord draws into the vagina. The umbilical, when we see taking the like any deep respiration, so that's why the umbilical cord is moving. So it means the placenta is still there. This means placenta is still there. This line we discussed yesterday. If you remember, the clamp put on the umbilical cord remain at the same level. We discussed like during the labor time, but we see the lengthening of the umbilical cord. Lengthening of the umbilical cord means when the placenta will be separated after the delivery, the umbilical cord, we feel that the umbilical cord is lengthening or the umbilical cord is coming out. So that's called the lengthening of the umbilical cord. Now we will see the clamp put umbilical remain at the same level, means the placenta has not been separated yet. So what the doctor further tactics, I told you that we follow the dangerous rules to prevent the PPH. So what we will do, we will put the hand inside and we will take the placenta out. So to do the manual removal after the manual. So what we will do, manual removal after the birth. Okay. Curettage, of course, we will not do. Curettage we will done in case of the post-partum cases or the post-abortion cases where the everything has been finished and there is some particles we know that okay, there is some fetal parts are there. In case of the post-abortal conditions, we do the curettage, all these things. But in this condition, we know that the placenta is there because the uterus is thick and the globe sets it giving the like we having the placenta is still inside. And this is the main keywords you need to remember. The clamp is on the same level. It means they wanted to say that only the placenta has not been separated till yet. So we need to manually remove the placenta. Okay. After that, a woman who has delivered the twins has early postnatal hypotonic uterine bleedings. So there you can see the hypotonic uterine bleeding is there, and in case of bleeding reach 1.5% of her body weight. The bleeding is going on. The conservative method to arrest the bleeding have been found ineffective. The condition of patients are the pale skins, acrocyanosis, oliguria. The woman is confused. And we can see the pulse is 130. The pulse is 130 BPM and the blood pressure is 75/50. What is the further treatments? So remember in these questions when we discussed about the, so this is the we having the firstly we have the twins baby. Firstly what we having the twins baby, and in case of the twins like we have the early postnatal hypotonic uterine bleedings. So we are seeing that there is a delivered the twins. So there is a twins body has early postnatal hypotonic uterine bleedings that reach 1.5% body weight. The bleeding is going on and the conservative method to arrest the bleeding have been found ineffective. So conservative method already done. The condition of the patients are pale skin, acrocyanosis, oliguria. The woman is confused, means the blood supply to the brain is also hampered. The pulse is 130, BP is decreasing, but the woman is going under the shock. So what is the further treatment? So in this case, what we need to do, we will take the uterus out, and what we call the uterine extirpation or the hysterectomy. Okay. Now let's discuss the hysterectomy further. Hysterectomy means that removal of the uterus, but it not just the removal of uterus. It can be the involvement of the cervix also, the vaginal parts also. So based on that, the hysterectomy, it is divided into the 5 types. One, we having the type 1. The first one is the type 1, and that is the simple hysterectomy. The simple hysterectomy is done, or we also call it as the total abdominal total abdominal hysterectomy. Total abdominal hysterectomy. Total abdominal hysterectomy. In these conditions, remember, this is the first of this is the most commonly preferred, hysterectomy, the most commonly preferred hysterectomy. And along with that, what we see, the most common indications, like if we having the fibroids, so it is the most common indication, of the type 1 or the type A or the simple hysterectomy. In this condition, what we do, we will remove the uterus plus we will remove the cervix as well. We will remove the uterus plus we will remove the cervix as well. If we will completely remove the uterus, cervix, tube, ovarian, everything will be removed, we call it the pan hysterectomy. Okay, so remember that type 1 or the simple hysterectomy, or we call it the total abdominal hysterectomy. The type 1 or the simple hysterectomy, we remove the uterus and the cervix. We remove the uterus and the cervix. Then there is a type 2. Hysterectomy. The type 2 hysterectomy, or we also call this as the modified radical hysterectomy. Modified radical hysterectomy. So in these conditions, we remove the uterus. Type 2 modified, it is the modified version, so it will remove the uterus. We remove the cervix also in these cases. We remove the both ovaries and the both fallopian tubes. Both ovaries and both the fallopian tubes. 1 centimeter of vagina will be removed. Some part of the uterine artery. Some part will be removed. In case of the modified, because it is a modified, so we have to, like if you have the, we will remove the complete part, uterus, the cervix, ovaries, 1 centimeter of the vagina, the uterine artery, everything will be removed. The third one is what? That is a type 3 hysterectomy. Or we also call it the radical hysterectomy. It is the not modified, it is type 3 or radical hysterectomy. In this condition, what we do, we remove the uterus. We remove the cervix, both ovaries and the tubes. Both ovaries and tubes will be removed. Then after that, entire cardinal ligament, and 3/4 of vagina. This is the important. The 3/4 of vagina will be removed in which conditions? Radical hysterectomy. That you need to remember. Type 3/4 of the vagina will be removed in case of the type 3 or the radical hysterectomy. Okay, then there is one other things, that is the type 4 and the type 5 also. That is not important, just remember these three. Type 4, it is involve the pelvic also, or the debulking surgery. Okay, that involve the type 4 and the type 5s. In case of the type 3, you need to remember the 3/4 of vagina has been removed. And in case of the type 2 hysterectomy, we remove the uterus, both ovaries, type 1 centimeter uterine artery. The type 1 or the simple hysterectomy, that is the most commonly preferred. The fibroid, that is the most common indications. And in the type 1, what we do, remove the uterus plus we will remove the cervix as well. Okay, is that clear? Okay, just give me 1 second. Till then, just complete the notes. हेलो ठीक है, समझ गया. Okay, is it finished? Now let's come back. So we have the question number. The woman who has delivered the twins. So the twins has delivered have early postnatal hypotonic uterine bleedings reach 1.5%. The bleeding is going on. Now you can see the bleeding is going on. And there is a hypotonic uterine bleedings. Hypotonic uterine bleeding, that it can be the decrease in the tones. We call this condition as the uterine inertia also, and this can convert into the atopy also. Atopy means atony means not atopy. Atony of the uterus, it can convert into the atony, means stones of the uterus can be gone. The condition the patients are the pale acrosinuses. We can see the 130 bpm and the bp. We know that this is case of the hypovolemic shocks, means there is a hypovolemic shocks, and we know that this is due to, like, if there is a loads of the bleeding is there, so that can lead to the low bp, high blood, or the tachycardia conditions. So this we can see that there is a chances of what the postpartum hemorrhage can be there, the postnatal hemorrhage, or because they deliver the twins baby, and the twins baby we having the postpartum hemorrhage is common. Then we treat the postpartum hemorrhage. Now you understand these things. When we treat the postpartum hemorrhage, so there is a two things. Like first we give the oxytocin, the uterine massage will be given, then we give the uterine tamponade. Then after that, if there is multiparous conditions, if the multiparous condition is there, then we give the directly, if multiparous condition is there or the multiparous woman is there, so in that things what we will do the subtotal hysterectomy. What we will do the subtotal hysterectomy. Subtotal hysterectomy means like the it is the, you can say, the type of the total abdominal hysterectomy. The type of the total abdominal is in which cervix will not be removed, but other parts will be removed. Cervix is not removed in the subtotal hysterectomy. Okay, but if it is primary parous conditions, if it is the primary parous condition is given, in the primary parous conditions, firstly we will give the uterine compression suture. We will do बहुत ताम झाम करते हैं प्राइमरी पैरस के अंदर. फर्स्ट वी विल गिव द यूट्राइन कंप्रेशन suture, then we will stitch the anterior or the posterior wall of the suture. Still there is a no response, then we will ligate the arteries, then first artery, then the branch of that artery, then after that the main branch of that artery. So all those artery will becomes, and in the end what we do the subtotal hysterectomy. This is done in the end. In case of the once the all our because in this question you can see the conservative method to arrest the bleeding have been found ineffective, because they did not give what is the multiparous or rigid primary parous, but they give the conservative methods to arrest the bleeding have been found ineffective. So in that case what we will do the subtotal hysterectomy. If subtotal hysterectomy is also not responsive, so we will give some umbrella pack or the parachute packs, but that is not for your level. Just remember, in case of the multiparously directly, because there is no need of the requirement of the children's, so we do the subtotal hysterectomy. Then in case of the primary parous, what we do, firstly we will take the uterine compression suture, then we will stitch the anterior the posterior walls. After that, if still there is a no response, we will try to ligate the arteries that is supplying that area, and due to which bleeding has been happening. So after that, once the every conservative methods has been ineffective, we go for the subtotal hysterectomy. Okay, and the hysterectomy, this is what the croak to name, that is the extirpations. Okay, that means they are doing the uterine hysterectomy. Extirpation means removal of the uterus. Removal of the uterus, the same meaning as the hysterectomy, removal of the uterus. So that is the extirpation, or we can say the removal. There's maybe some English name, or I don't know what is the name of this, but this is what hysterectomy. So you need to remember this key, this terminology also. Extirpation means hysterectomy. Oh, just a second. Oh, it's for Uttarakhand. I thought it's Ukraine. Then after that, the next questions. A 26-year-old woman complained of the mild bloody discharge from the vagina and pain in the lower abdomen. So we can see there is a mild bloody discharge and there is a pain also. Last menstruation 3.5 months ago, means she is pregnant 3.5 months pregnant. The pulse is 80, the blood pressure is normal and body temperature is again like a little bit normal. The abdomen is tender in the lower part. The abdomen is tender in the lower parts. The uterus is enlarged up to 12 weeks of the gestations. What is your diagnosis? देखो, uterus is enlarged up to the 12 weeks. Did we studied about the fundal height and the gestational age? The fundal height, the height based on the gestational age. Height by gestational age. So height by gestational age, what is that? That is the 3.5, means that will be around 13 point or the 14 somethings. Okay, that is the 14 weeks. But here we can see the fundal height is less than the height by the gestational age. Now, but when you will see your abortion part, in the fundal height will be less than the height of the gestational age we discussed in case of the inevitable abortions, in case of the incomplete abortions, in case of inevitable, in case of incomplete abortions, and in case of missed abortions. In all those things what we discussed, the fundal height will be always less than the height by the or the period of the amenorrhea, or height by gestational age or the period of amenorrhea. Then we discussed that the fundal height will be equal to the height of gestational age or equals to the period of amenorrhea. So this was the case of the threatened abortions. Also remember, in case of the threatened abortions, what we discussed, the internal os will be open or closed. The internal, IIIO means I, inevitables, incomplete, or there is one more I is there, and O that will be the open. O means open internal os. Here the internal os will be closed. They didn't give anything related to the internal os, so we need to figure that things. How it will be the inevitable abortions. Okay, so based on that we can see the fundal height is less than the height by the gestational age, the period of gestations. So that's based on that we will consider it as the inevitable abortions. Okay. Why it is not threatened abortions? Because there is a fundal height in a threatened abortion. There can be the two possibility in these conditions. One, that it can be the inevitable, other it can be the threatened abortions. The fundal height will be equal to period of gestation, that is seen in threatened abortions, and in this question we are seeing the fundal height is less than the period of amenorrhea or the height by the gestational age. That's why the answer here is the inevitable abortions. Okay. Rest I think there is some more questions, but once it will comes we will discuss. Then in 18 years, the next question, compared to the pain in the lower abdomen, some minutes before cesarean suddenly appear unconscious at a time. So unconscious at the home. The patient had the no menses within the last 3 months, means 3 months pregnant. 3 month pregnant. If 3 month pregnant, it can be the intrauterine pregnancy. It can be the which conditions? Ectopic pregnancy or extrauterine pregnancy. And on examination, the pale scale, the pulse, the BP is decreasing, the cytokine signs, or we call it, the full name is the Cytokines-Bloomberg sign. This is like the sign for the rebound tenderness, the sign of rebound tenderness. And this is seen in case of the peritonitis. So when we will touch the peritoneum area, once we will release our hands, once, like for example, hello. Let me just connect to another Wi-Fi, another hotspot. Wait. पता नहीं यार सेम वाईफाई है आज, पता नहीं क्या इशू आ रहा है इसमें. हाँ वही मेरे को भी ऐसे लग रहा है यार, क्योंकि ना अभी इसमें मेरे को आवाज थोड़ा सा लगा था कि कहीं प्रॉब्लम आएगी नेट की, तो इसी वजह से ना मे भी मोबाइल नेटवर्क इशू आ रहा है थोड़ा सा. क्योंकि डेली तो मैं इसी से क्लास लेता हूँ. ओके थोड़ा बहुत होगा, ज़्यादा नहीं होगा, ठीक है, जस्ट लिटिल बिट फ्लक्चुएशंस एंड आई थिंक उससे ज़्यादा नहीं होगा. So did you hear what I said? So I was discussing about the Sotkin's-Bloomberg signs. Sotkin-Bloomberg sign means rebound tenderness. Rebound tenderness. See, when we what is the rebound tenderness? When we having like when we putting any pressure. See, when we are doing like putting any pressures, like for example, if like this is my hand and I am pressing these regions. If I am pressing, this is the like assume this is the peritoneum regions. Assume this is the peritoneal regions. If you will assume this is the peritoneal regions, if I am pressing that regions with the pressing that regions, हाँ भाई बता रहा हूँ. Just this is what this is the. Let's now first hear about the rebound tenderness. Let's assume this is the peritoneum. This is the peritoneal regions. So when I am pressing this regions, so there what we will see when I am pushing it back, so there will be the rebound tenderness and there will be the pain when I will keep it out. When I will keep it out these fingers, then there will be the pain. We call this as the rebound tenderness, and this is the Bloomberg sign that is seen in case of the peritonitis. 42 also again. 42 भी नहीं आया क्या? 42 तो हो गया ना. So what we are seeing in the questions, there is a mild the mild bloody discharge from the vagina and pain in the lower abdomen. See here the last menstruation 3.5 months back, the pulse is 80 bpm, the blood pressure is itna. So what I was saying, then we discussed the abortions part. So in that case we discussed the fundal height is less than the height by the gestational age or the period of amenorrhea. Okay, and fundal height will be less than the height where we wrote in case of the inevitable abortions, in case of the incomplete abortion, and in case of the missed abortions. In all those things what we wrote, the fundal height will be less than the period of amenorrhea. Then the next one we discussed, the fundal height will be equal to the period of amenorrhea, that is the threatened abortion, that is the threatened abortions. But in threatened abortions what we discussed, the internal os is closed, and inevitable or incomplete what we discussed, the internal os will be closed. So there is a two possibility, it can be the inevitable or the threatened abortions. So in these conditions what we will see, that this the threatened abortions will not possible because fundal height is equals to the period of amenorrhea. Okay, then that's why it will be, the answer will be the inevitable abortions will be there. And along with that we see there is a pain will be there. The pain will also seen in case of the inevitable also abortions. I wrote it there, the pain and the bleedings, the discharge, the blood discharge is there, and after that I wrote there is a non-significant something like that. Okay, so that is what inevitable abortions. Okay, that's why I'm saying keep revising whatever the materials, because I will just quickly revise these topics only. Then we will be having I was here. A woman complained of pain in the lower abdomen. Some minutes before, she has suddenly appeared unconscious at the homes. Now, she having the pain in the lower abdomen. Some minutes before, she has suddenly appeared. She has suddenly appeared unconscious home. The patient had no menses within the last 3 months. So she had no menses within the last 3 months. It means what is that? That is the 3 months pregnant. She is 3 months pregnant. If she don't having the menses, so what comes in our mind? Intrauterine pregnancy. It can be the extrauterine pregnancy. It can be the molar pregnancy, or the molar in molar it can have the partial pregnancy. Okay, let's just assume that the pale skin, the pulse, BP is less. BP is less means there is a something is wrong, and we know the BP, if pregnancy BP is decreasing, the blood pressure is decreasing, that can be the ruptured pregnancy only. The Bloomberg sign or the cytokine sign is the positive, so that is means peritonitis is there. The vaginal examination, the uterus is little bit enlarged, the displacement is painful, any lateral swelling. There is also any lateral swelling of the intestine side. The posterior fornix of vagina tender overhang sides. So this is all due to impaired extrauterine pregnancy, or we can say we discussed, I think there was a question before also, that the broken tubal pregnancy. So this is again the impaired extrauterine pregnancy or the ectopic pregnancy. Okay, it cannot be acute appendicitis, because acute appendicitis they will not give you such history about the pregnant lady and all those things. Okay, somebody was asking yesterday about that why it is not ovarian apoplexy or ovarian torsions, why it's not ovarian torsions. So why? Because she having the pregnant history. The same question was before, and also there was the pregnant history was there. That's why. These are the same questions that we just discussed today about the placental presentations. Then question number 45. In question number 45, in the gynecological office, if 28-year-old woman complained of the sterility within the 3 years, the menstrual function is not impaired. There were one artificial abortions. And chronic salpingo-oophorytis. Chronic salpingo means fallopian tube or the ovary. The inflammation in her case history. Oral contraceptives were not used. Her husband analysis semen is without pathology. Means husband is all right, no problem with the husband. What diagnostic method will you start? Dekho, what diagnostic method will you start from the workup in this case of the sterility? So when you will start, if they will give you something about the start, so remember that is the hysterosalpingography. Okay, so let's discuss these things. Okay, so let's discuss about the infertility. Let's discuss little about the infertility, because there are many questions regarding the infertility. So infertility. So what is the definition? The first things, that is the universal definition of this. If any couple having a failure to conceive even after 1 year of unprotected sex, failure to conceive even after 1 year, even after the 1 year of unprotected and regular intercourse. This is the universal diagram. Just copy paste this in your mind and never delete this. The infertility, the failure to conceive even after, every point of this sentence is important. 1 year also, the 1 year unprotected and should be the regular intercourse. There can be the primary means she never conceived before. Primary means she never conceived, like never conceived, she never delivered any children before, so she never conceived it. Secondary, she conceived before, but now she is having the problem, and now she is facing difficulty to conceive. Okay, I hope you will write this. This is what the secondary. What is the sterility, and what is the difference between the infertility and the sterility? The infertility and the sterility means that absolute inability to conceive. The absolute inability, because infertility can be treated but sterility cannot be treated. So this is the absolute or the permanent inability to conceive due to permanent damage to the gametes. Conceive due to permanent damage to the gametes. For these couples, they need surrogacy or in vitro type of the fertilizations. Permanent damage of gametes. Okay, the female, they are like 40 to 45% females are the region for the infertility, and in the male that is like 30 to 35%, others are idiopathic. Okay, then remember that it can be like seen at the different level. Like for example, if we having the, it can be that due to anovulation, and the when we talk about the infertility, as we are discussing about the gynecology part, so mainly we discussed about the female infertility, because female infertility, and in case of the female infertility, the most common cause is what? That is anovulation. The most common cause will be the anovulations. The most common cause will be the anovulations. The causes of anovulations can be the class 1 HPO axis failure, HPO axis dysfunctions, and the premature ovarian failure, hyperprolactinemia. There are the different regions, and the second most common is the tubal patency. The second most common cause is the tubal patency, and this will be at the ovular level. This will be at the ovular levels. So ovary level. So anovulations, and the second most common is the tubal patency. In your exam, they ask you about the tubal patency. Anovulations, I hope you all are clear about that. If a FSH and LH will not work properly, that can lead to the anovulation like a problems. But if we talk about the tubal patency, they will ask you what about the, like, how you will diagnose the, how you will investigate this type of the things. So that you will how you will diagnose that things. So for the diagnosis of tubal patency test, they will ask you. Then in case of the diagnosis of the tubal patency test, what you need to do, first of all, the first things that will be the hysterosalpingography. That will be the hysterosalpingography. Graphy means X-ray. So this is the X-ray. Graphy means this is the X-ray, and we can write it the HSG. That is the hysterosalpingography. Okay, what is the region of that, like the tubal blockage or the tubal patency or the tubal, or we can say the tubal blockage? So it can be like due to, if there is any PID, if any PID is there, it can be the salpingitis, it can be the endometritis. All these can be the regions. Okay, like the PID, in PID what we discussed, the salpingitis, the endometritis, all they can block the tubal blockage. So the first things we will do, that the to test the patency of the tubes, we will do the hysterosalpingography, and this is the OPD procedures. We will use a dye. We call the remember the name of the dye also, that is urographene dye. Urographene. This is the radio opaque dye, and it is inserted into the uterus. Via, there is a cannula name, remember, Leach. It's not niche. Leach-Wilkinson cannula. It is not Lee. It is the Leach-Wilkinson cannula will be there. Other than that, what we can do, like if we want to use the ultrasound. So for the ultrasounds, we will be having the sonosalpingography. Sono means sonar, ultrasound, sonography. Sonosalpingography by ultrasounds. Yesterday we discussed the one things, that is the laparoscopic, which conditions, chromoperturbations. Laparoscopic chromoperturbations. So that is the best diagnostic test to diagnose the infertility. The best to diagnose the infertility is the laparoscopic chromoperturbations. Can you tell me which question was that? So let's come back to the question number 37. So in 37 you can see this is the most informative in the diagnosis of the tube infertility. So what is the answer? Laparoscopy with chromosalpingography. See, in this question we will be having the hysterosalpingography also. So hysterosalpingography is for the start. So remember the hysterosalpingography for the start regions. Okay, then we have the laparoscopic chromoperturbations. If any uterine factor is involved, what are the uterine factor? Like the septate uterus is there. If infertility due to uterine factor, in uterine factors we can having like the septate uterus, we can having like example submucous fibroids can be there. So septate uterus, submucous fibroid can be there. This if infertility due to uterine factor like septate uterus or the submucous fibroids. So in that case what we will do, we do the hysteroscopy. What is the hysteroscopy? Hysteroscopy क्या होता है? In case of the hysteroscopy, remember what we use, it is like the telescope. What we do, telescope is inserted. And based on that we will visualize the endometrial cavity, we will visualize the cervix, then we can visualize the endocervical canals. So we will endocervical canals, and the most commonly they are used in case of the hysteroscopy. The most common indication of this is the infertility. But remember, infertility due to uterine factor. The most common indication is the infertility, and infertility it is due to uterine factor. If uterine factor is involved, means there can be the septate uterus or the submucous fibroid. In that case we use the hysteroscopy. See, if the PID cases or all these things, for that we know the hysterosalpingography. In hysterosalpingography what we are doing, we are putting a dye through the vagina that will go to the cervix, then go to uterine cavity, then it will spread, and it spread to the into the tube, fallopian tube. From the fallopian tube it will go to the ovary regions. In ovary it will spill. If we see that in ovary it is spill, there is spilling of this dye, so means there is no tubal block. But if there is no spilling is there, means the dye is not going further, so that means there is some blockage is there. Okay, so that's why we use the hysterosalpingography. In case of hysteroscopy, we use the most common infertility due to uterine factor like the septate uterus, some mucous fibroid. In all those cases we use the hysteroscopy. Okay, or also we can use in this case of the like atypical uterine bleedings. This is also used in case of the atypical uterine bleedings, and along with that we can also use in case of the postmenopausal bleedings. We use the hysteroscopy. Okay, the first test you need to do, remember to done. The first test to done to visualize the tubal patency, that is the hysterosalpingography. The first test done to visualize tubal patency, that is hysterosalpingography. Okay, I hope this is clear. These are very important. There is one more question about these things. So the diagnosis of the tubal patency, hysterosalpingography, sonosalpingography, laparoscopic chromoperturbations. So if first things like in the questions, See, the diagnosis will you start from the workup. So you need to start from the hysterosalpingography. So firstly, and also we can see this patient is having the history of the PID also. So if the history of the PID, of course there can be the chances of the tubal blockage. So in that we will start with the hysterosalpingography. Okay. Then this question is direct questions. AP, PS. So what is the transfusion shock? That means patient will be in the shock. Okay. Then question number 47. A 58-year-old woman came to the antenatal clinic complaining of the bloody light red discharge from the genital tract. Menopause is the 12 years. Uterine cervix unchanged. The scant bloody discharge from the. Okay, this is the case of the carcinoma. So leave this also. And leave this also. Okay, we will discuss one together. This one we already discussed about the trichomonas vaginalis. I think this was question number 2 or question number 3. The treatment of the specific colpitis and the subsequent biopsy. The question number 51. If 76-year-old secundipera at 40 weeks of the gestation. Secundipera means second time delivery. Secundipera at 40 weeks of gestation arrived at the maternity ward after the beginning of the labor activity 2 hours before bursting of the water, hence proved 2 hours before bursting of the water occurred. Water in pregnancy, what is that? Amniotic water. The fetus was in the longitudinal lie with the cephalic projection. Very good, she is good. Abdominal circumference was 100 cm, fundal height 42 cm. Contraction occurred every 4 to contractions occur every 4 to 5 minutes and lasted 25. It should be 45 seconds. The internal obstetric examination revealed cervical effacement, opening by 4 cm. Fetal bladder was absent. Fetal head was pressed against the pelvic, and what complication arose in the childbirth. So we are seeing that in these conditions, what we are seeing, there is a bursting of the water occurred. The bursting of water means directly came in the should come in our mind. What is that? Amenorrhea. This is not amenorrhea. Not amenorrhea. Okay, don't confuse. Maybe they give in the question also. They are the good examiner. They did not give, but they can give the amenorrheas. This is the amniorrhea. Amenorrhea. What was the amenorrhea? Absence of menstruation. So here the amenorrhea means discharge. Rhea means discharge. So discharge of what? The discharge of amniotic fluids will be there. Discharge of amniotic fluid will be there. Okay. ठीक है यहाँ तक. Did everyone wrote it? Then the next question. A 28-year-old parturient complained about the headache, vision impairment, psychic inhibitions. AP, preeclampsia like conditions, evident edema. Okay. Then anterior abdominal, fetus head in the area of the small pelvis, fetal heartbeat clear, rhythmics. Internal examination revealed complete cervical dilatation. Fetus head was in the area of the small pelvis. What tactics of the labor management should be chosen? Okay. So there is a complete cervical dilatation. Fetus head is in the area of the small pelvis. They give many clues. Firstly, we having the AP, the BP is high. Okay, we can having the eclampsia conditions, and the area is in the area of the small pelvis, and there is a complete cervical dilatations as well. So in these cases, what we will do the forceps delivery. In which conditions we do the forceps delivery? If we have conditions like the fetal distress. The fetal distress conditions, and in conditions like the patient if having the prolonged second stage, the prolonged second stage of the labor. So in those things, what we will do, we do the forceps operations. We will not do the cesarean because we can see there is a complete cervical dilatations is there, and the fetal head is in the area of the pelvis, so it descend down. So that's why we need to take the forceps. Like the forceps we can use like the Wriggles forceps, like Krillens, Pipers, Truckers. So these are the forceps that we use during the forceps operations. I'm writing the one name, that is Wrigley. That can be, these are forceps. That remember the name of the forceps, the Wrigley forceps is there, that help in the delivery of the using the instrument, or we can call it the instrumental delivery. Okay, that is the forceps operations. After that, this question, there is a second labor, had born a girl with a manifest anemia and progressive jaundice. The child weight was 3, length was 52. The woman blood groups, what is that? Female blood group is Rh negative. The father blood group is Rh positive. Okay, so this is the case of the Rh incompatibility. Okay, we discussed it many times. If mother is Rh negative, if mother is Rh negative, father or children is Rh positive, so there will be the Rh incompatibility, or the rhesus incompatibility will be there. So this you need to remember. Remember just these things. If anyone have any doubt in these things, I hope no. Does anyone have any doubt in this? दोबारा से स्क्रीन स्टॉप शेयरिंग हो गई क्या? ग्यारह 39 पे भाई सही तो चल रहा है यार. अच्छा हल्की सी लैग हुई थी. ओके ठीक है. So this is what the rhesus incompatibility. Okay, the forces operations and the rhesus incompatibility. Then come back to the question number 55. If 37-year-old primary gravida woman, a 37-year-old primary gravida woman has been having labor activity for 10 hours. The labor pain lasts for 22. देखो, she has the labor activity for 10 hours. Then labor pain lasts for 20 to 25 seconds every 6 to 7 minutes. Okay, the fetus lies in the, so let's first discuss what we, let's revise about the yesterday one. Okay, so what we discussed, the normal uterine contractions, the adequate uterine contraction, what we studied, 3 contraction in the 10 minutes. Each contraction should last for 45 seconds. Pressure should be 65 to 75 mmHg or 200 to 250 multi volt unit. Okay, so that you need to, that should be in your mind. 3 contraction in the 10 minutes. Each contraction should be last for 45 seconds. Pressure 65 to 75 or 200 to 250. Okay, now come back to this one again. So there we can see the labor pain for 20 to 25 seconds every 6 to 7 minutes. Every 6 to 7 minutes. Okay. So the fetus lies in the longitudinal. The presentation is, this one is correct. The cephalix head is placed upon the entrance to the small pelvis. Vaginal examination result, the cervix of uterus is up to 1 centimeter low. Let the 2 transverse finger in. Fetal bladder is absent. What is the most probable diagnosis? So before that you should understand what is the uterine inertia. Okay, so uterine inertia means this is like the common type of the uterine inertia. The uterine inertia, remember, it is the common type of, or we can remember another name first, that is the hypotonic uterine dysfunction. That is the hypotonic uterine dysfunctions. Hypotonic means less tone, decreased tone. Hypotonic uterine dysfunction. So this type of the uterine inertia, that is the abnormal uterine, the common type of the abnormal uterine. This is the common type of abnormal uterine contractions. Common type of abnormal uterine contractions, but it's not that serious or not severe conditions. It's not that serious conditions. It may complicate any stage of the labor. It can be the stage 1, stage 2, stage 3, or stage 4. It can start like from the beginning of the labor, and like it subsequently after a variable period of the effective contractions. So like from the beginning of the labor till the end of the delivery, till the end of the placenta, any problem in the uterine contractions or the hypotonic uterine dysfunction is there, we call it as the uterine contraction. What we will see in these conditions, the intensity will be diminished, means the intensity will be decreased, the durations will be short, the durations will be shortened. So the durations of these conditions will be shortened. What we will see other than that, we discussed that there is a relaxation and the contractions. The lower segment, the relaxed, upper part will be contracted. So what we will see, there is a good relaxations will be seen in between the contractions, and the intervals will be increased. The interval between the contraction and the relaxation will be increased, means it become the discoordinated, some little bit discoordinated. Interval between contraction and relaxations will increase. How the patients will feel in this condition? The patients will feel less pain like during the uterine contractions. The patients will feel the less pain during uterine contraction. If a uterine contraction is there, he will feel the less pain. Other than that, the uterus will become relaxed. The uterus should be contract at the time of the labor, but the uterus will become relaxed in these conditions. And internal examinations, when we do the internal examinations, in case of the internal examinations, what we will do, we see there is a poor dilatation of the cervix. What we will see, the poor dilatation of the cervix will be seen. There will be the poor dilatation of the cervix will be seen. We see there is a the cephalopelvic disproportions, along with that malpresentations will be also seen. All these things will be done. So remember that what is the uterine inertia here, that if any hypotonic uterine contractions, we call this condition as the abnormal uterine contractions, we call this condition as the uterine inertia. The intensity, the durations, and there is a interval between the contractions and the relaxations periods will be increased in these conditions. The persons will feel the less pain during the uterine contraction. The uterine will become the relaxed. Internal examination, what we will see, the poor dilatation of the cervix will be seen. The other important point that you need to remember here in this condition, the effect on the effect on, what will be the effect on mother and fetus, the effect on the mother and fetus. So effect on the mother and fetus, what we will see the maternal mother will be exhausted, because as I told you, exhaustions, maternal exhaustion, because there is a like the we can see that if the intensity will be decreased and the durations will be shortened, the uterine contraction durations will be shortened, that's why the labor will be prolonged. And then once the labor will be prolonged, the mother will be completely exhausted, and the fetus can undergo the fetal distress. Fetal can undergo the fetal distress. Okay, but this, they usually not appear, they appear lately, because once the it will become so much prolonged that at that time the maternal exhaustions or the fetal distress will be seen. So here in these questions, if you are getting such type of the questions, the labor activity for the 10 years, the labor pain lasts for the presentation, everything is normal, but there is a problem in the tone of the uterus. In sometimes they will give you something directly in the question, hypotonus. So that's why we will get to understand this is the primary uterine inertia. There is one more question about the discoordinated labor activity. I think question number 122. Let's come back to question number 122. Okay, in this condition, see the question number 122. A 30-year-old parturient woman was taken to the maternity house. So, how a 30-year-old, it is a 30-year-old parturient woman taken to the maternity house with the complaint of having acute regular labor pain that lasts 25 to 30 seconds every 1.5 to 2 minutes. Labor activity begins 6 hours ago. The uterus is in the higher tonus. If uterus is in the higher tonus, now see there I told the uterine inertia, what we will see that the tone of the uterus will be decreased, hypotonic uterine, or that will cause the inadequate uterine contraction or abnormal uterine contraction. The head of the fetus is above the opening into the small pelvis. The fetal heartbeat, cervical dilatation is 4 centimeter. Now everything is going smoothly, but what we are seeing, the cervical dilatation is 4 centimeter. Uterine forces is spasming at the height of peridynia. Head is level with the opening into the small pelvis. It is being pushed off. So what is the most probable? Means labor wants it to happen or the baby wants to be delivered out. But this is like the sometimes uterus will be in the higher tonus. Sometimes there is cervical system. Uterus is everything is going normal. Uterus in the high tonus means uterus is completely contracting. And there is a regular labor pains is also there. Regular labor pains is also there. So, but the problem is with that the cervical dilatation is not there. You can see the cervical dilatation is 4 centimeter. The cervicals is still in the latent or the active phase, but it should be having the complete dilatations, while the uterus is in the complete haunted. That's why there is some discoordinations between the labor activity. That's why they give this terminology as the discoordinated labor activity. Okay, this terminology is specific just for the Croc 2 exams, not for further exam. Discoordinated labor activity. Okay, and that what we discussed. Now let's come back again to that question. Our question. So in this question we will be having hypotonus conditions, like everything is going normal and the primary gravida, the labor activity for the 10 hours. That means the baby like the woman undergo the prolonged periods. But in these conditions we will be having the problem with the uterus, the uterine inertia problem. Uterus is not able to contract. In that thing uterus is hypertonic but the cervix is not able to dilate. That's why they will be having the problem with the discoordinations. So that is the discoordinated labor activities. Okay, so if this type of the questions will comes like if you need to differentiate, I think most probably the answer will be the uterine inertia only. In case of the discoordinated labor activity, they will not give the option uterine inertia. Okay, why it is primary not secondary? Because it's not due to any, no, they didn't mention any other pathology related to that. That's why it is the primary conditions. Okay, now let's go to the next questions. Again, this is the ovarian tumor. Okay, now let's come back to the we will discuss about the breast topics in detail. Okay, before that you can take the I think 10 minutes break and then we will start. I hope till now everything is okay. You are understanding everything. See, I know that in case of obstetrics or gynecology, I told you that the questions are little bit. You can feel now that it's a little bit hard for you if you did not study with the previous materials. Okay, then remember that things like if you are getting these questions like this type of the questions, once you will revise all those things, it will become easy for you. So don't worry if you are feeling like if you have any questions, problems and difficulty in understanding any concept also, if you will keep revising all those things, it will become easy. Okay, so let's take a little bit breaks and after that I will discuss it. Okay, so we will see you at 12:05. Okay, after the 10 minutes. What was the question number 42? Okay, until you can make the notes. पेन हो गया यार. Okay, so let's come back. क्वेश्चन नंबर 42. अरे यार अबॉर्शन का क्वेश्चन है तो देखो. इन 26-year old woman complained of the mild bloody discharge from the vagina, pain in the lower abdomens. So what we are getting, there is a mild bloody discharge. Say the last menstruation 3.5. So means that is the period of amenorrhea, or we can say she is 3.5 months pregnant. So 3 multiplied 4 is equals to 12 weeks. Okay, and 5.5 means it will be the 14 weeks. The period of amenorrhea will be 14 weeks. The pulse is 80 bpm, the blood pressure is 110 and temperature is 36. The abdomen is tender in the lower parts. The abdomen is tender in the lower parts. There is a pain in the lower abdomens and the abdomen is tender in the lower part. The uterus is enlarged up to 12 weeks of gestations. So this is the fundal height. The uterus is enlarged. So the uterus is how much uterus is saying that is enlarged. They didn't mention what about the ultrasounds and all those imaging, but according to that, this is enlarged up to the 12 weeks of the gestations. Okay, they enlarge up to the 12 weeks of the gestation. So we will. Okay. Yes. They did not give the fundal height. Here. This is again the same things about the period of amenorrhea. They counted it as the 12 weeks of the gestation. So for now, just remember that if the fundal height is there less than the height of gestation, inevitable, incomplete, or the missed, the fundal height is equals to period of amenorrhea. That is the threatened abortions in which you see, and the internal os will be closed. Now in this question we can see now we need to rule out this option because they didn't mention anything related to that, and we know that in case of the inevitable abortions or in case of the incomplete abortions, we will be having the internal os will be open, and in case of the threatened abortions, the internal os will be closed. Missed abortion also, the internal os will be closed. Okay, then you need to remember ki if there is something like in case of the inevitable also, there is a live intrauterine pregnancy but there is open cervical loss. So we need to, in this question they didn't mention anything related to that. So now let's come back to the options. Okay, so if you see the incipient abortion, the incipient abortions means like the spontaneous type of the abortions. Okay, the initial stage of the abortion, that is the incipient abortions. The complete abortions, that cannot be here. The complete abortion means the cervix vein will be fully dilated, but they didn't mention anything related to that. So that is the complete abortions. The dysfunctional bleedings, the dysfunctional bleeding is not related to the abortions. It can be or not related to the pregnancy also. Okay, the dysfunctional bleedings, like it can be the oligomenorrhea that we discussed in the, I think, our second video. Then we will we will be having the incomplete abortions. Now we will be having the two options, that is the inevitable abortion or we can having the incomplete abortions. The incomplete abortion, they will give you the history of what? Which history they will give? The incomplete, the history of something is like passing out, the history of product of conception, the history of the product of conceptions that we wrote there. The incomplete abortion, the history of the product of conception is mandatory, they will write. So that's why it will not be the, because they didn't mention anything, that's why it's not the incomplete abortions. So we have the only the one option is left, that is the inevitable abortions. This question having sums, as this is not all the details given in the questions, so that's we need to rule out all the options. Okay, so this is not the fundal height. I thought that is the fundal height by mistakenly. So this is not the fundal height. Okay, so that is the inevitable abortions will be the answers based on the rule out the options. And you know what is the inevitable, what is the threatened abortions, that you need to remember by yourself. Okay, that's why you are all confused. That's why this is the answer. And there are like many questions will come about the threatened abortion, so we will keep discussing that, so your concept will be clear. Now is clear? Siddharth Singh's, or somebody has also asked me before, I think. Mani Dheeraj. Is it clear now? ठीक है. You will get the proper details यार. लेकिन like मैंने भी एक चीज देखी in the my paper also, there was the complete informations. But some questions you will get like this only, in which you will not get you will get the two answer also. That the two answers will be exactly correct sometimes, but there are the not so much questions. There will be one or the two questions will be there. So you need to just rule out the options like that. Okay, so let's discuss further what was discussing about the breast part. Okay, leave these topics for the breast parts. The breast topics, like I will upload it on the YouTube channels for the all students. Okay, all the breast parts, because this is like important question, so everyone can having the this paper. Okay, so just revise till these things, and just be prepared for the exams. Maybe 28, 29, 30. I don't know. I will tell you the date, exact date for that. So just be prepared for that exams.